Good afternoon. This is Dr. Robert Wynn. I want to welcome you to this amazing session, we hope, on food insecurity among patients with cancer. Before we do that, though, I would like to actually go over a couple slides. Next slide. At the National Cancer Policy Forum, the National Academies has created this NCP forum to serve really as a trusted venue to examine high priority policies, issues in cancer research and care. The forum activities really does identify opportunities for action to reduce cancer burden through prevention and by certainly improving the care and outcomes from those diagnosed with cancers. Next slide. Here are some of the sponsors of this National Cancer Policy Forum. You can see that there's a number of sponsors that are listed here, and we are grateful for their sponsorship. Next slide. This is really could not have been done without help. And in fact, the Food and Nutrition Board, as well as the Committee on Applied and Theoretical Statistics, are part of organizing and putting this forum that you will sort of see in this webinar together. And we want to again say thank you to both those groups. Next slide. The webinar planning planning group consisted of me. I was a chair, but could not have been done without a number of the people that are listed here. Karen Besson from MD Anderson, Kathy, Gwen, Ann, Raphael, Margaret, Hillary, and Robin, and certainly could not have been done without the National Academy staff, who we were forever grateful for their help and support in helping us to shape this webinar as well as put it together and really those final points of making it a good program. So again, thank you. Next slide. The webinar presentations you'll hear today will be the historical perspectives, because we do believe that giving a framework to this issue around systemic food insecurity, particularly in the United States, is important. We're going to be also talking about conceptualizing of what food insecurity is, as well as looking at research surveillance needs, the patient advocacy strategies to address food insecurities, as well as the policy levers to address food insecurity. And you can see the folks listed there, from Raphael to Stacy, Francesca to Shanta to Hillary. These will be the main speakers, and then we'll obviously have a panel. Next slide. I will be one of the moderators. My partner in crime is going to be Gwen Darren from the National Patient Advocate Foundation, and she and I will be guiding us through this sort of webinar. And our discussants will be Jessica, Dorothy, Macy, and Kristen from the various organizations that will actually help round this panel out. Next slide. So as we begin with the first speaker, I want to actually also remind us that I think COVID has done a number of things for us, but it has really put a framework and has crystallized this issue around food insecurity. I believe that as this has become an issue, it has become much clearer that this is an issue that must be addressed and has a particular and unique impact, adverse impact on our cancer patients. And I think it's with that mind, more than anything else, we really have tried hard to sort of bring this to all of our attention. So I think we'll go from here is to now talk a little bit about our first presenter, Raphael.
Thank you, Rob. I am honored to have been asked to give you a brief historical perspective on food insecurity in the US. Next. The first objective of my talk is to contextualize the quote-unquote discovery of hunger in the US in the 1960s. The second objective is to summarize the implications of food insecurity monitoring for policy and practice. Next, please. To achieve these objectives, I will focus first on the 1969 White House Conference on Food, Nutrition, and Health, and then on the launch and implications of the US Household Food Security Survey module. Next. The 1969 White House Conference on Food, Nutrition, and Health was a truly multi-stakeholder landmark event, which led to the implementation of hundreds of recommendations to improve public health nutrition in the country. And by the way, it is the only White House conference that has ever taken place focused on this topic, hosted by the president. Next, please. As you will see in the next slides, this White House conference happened because of the powerful combination of evidence with activism, plus dramatic changes in public opinion as a result of huge media coverage and strong political support. Next, please. The evidence came from different sources, including local hunger commissions, which led to the congressional mandate to conduct the 10-state nutrition survey in 1967 that documented widespread nutritional problems in poor areas in the country and very clear ethnic racial disparities in the distribution of these nutritional problems. Next. The conference also happened as a result of individuals who became highly recognizable activists, such as Marianne Wright Elderman and Jesse Jackson, as well as frontline community members. I took these pictures from the video taken during their most thoughtful remarks during the conference. Next, please. There is no doubt that the CBS documentary, Hunger in America, aired in 1968 and that immortalized the TV journalist Charles Kuralt, had a huge impact in public opinion, which in turn helped firm up the political pressure needed for the 1969 White House conference to happen. Next, please. This documentary took the audience through a very painful journey across Alabama, Kentucky, Navajo Nation, and Texas, showing incredible high levels and very strong ethnic, racial, and zip code-based inequities in the distribution of hunger, clearly illustrating for the first time in front of a national audience that hunger was indeed a social determinant of health issue. The documentary included statements from a San Antonio senior commissioner stating that poverty always needs to exist because there will always be the need for Indians and chiefs. And it was not only poverty, but he said poverty and hunger. And furthermore, that education beyond 8th grade was unnecessary for hungry people, as some people were not even worth a dime. Even though, understandably, the documentary focused heavily on undernutrition, it did address the importance of dietary quality and did show images of hungry, overweight people. At the end of the day, the documentary led to strong bipartisan support to not only acknowledge, but to actually do something about food insecurity and hunger in the nation. Next, please. The building of strong political support received a strong boost through the poverty finding mission to Mississippi, led by Democratic Senators Joseph Clark and Robert Kennedy in 1967, where they heard about and witnessed directly the meaning of extreme poverty and hunger in that part of the nation. Next, please. The 1969 White House Conference on Food, Nutrition, and Health officially recognized hunger as a national crisis, and its evidence-informed report was released with strong bipartisan support. It received huge national press coverage and, most importantly, was acted upon immediately. Next, please. So to sum up, the 1969 White House conference, a historical case study, illustrates how evidence of the discovery of hunger ended up leading to strong media coverage and related public reactions, which in turn were responsible for the huge bipartisan support that led to improving our ways to address hunger in the country from a societal point of view. Next, please. The legacy of this conference has indeed been enormous. First, the very strong bipartisan support was reflected in the establishment of the Senate Select Committee on Nutrition and Human Needs that was co-chaired by many years by George McGovern and Bob Dole, each of which belonged to a different political party. Next, please. The legacy of the White House Conference when it came to the endorsement or application or adoption of 70 to 80% of all recommendations, over 1,000 recommendations were implemented, led to a major expansion of the SNAP program, major expansion of school feeding programs, the establishment of the WIC program in 1974, the establishment of the National Health and Nutrition Examination Survey Systems, the dietary guidelines for Americans. To the right of the slide, you can see the historic document of the first sort of recommendations that were released in the late 70s, entitled Dietary Goals for the United States by the Senate Select Committee on Nutrition and Human Needs. Interestingly enough, these first dietary guidelines did address diet, obesity, and chronic diseases, including the topic of cancer. Furthermore, the White House recommendations led to the establishment of the mandate for nutrition labels in food products. So as you can see, the modern era of food assistance programs and support networks and policy activities are a direct result of the 1969 White House Conference. Next, please. So I want to invite you to learn more by reading this excellent 50th anniversary report of the conference that was published by Tufts University after doing a major celebration to actually memorialize the occasion and probably to call for a second White House conference on this topic in the very near future. Next, please. The second and last part of my talk will focus on the US Household Food Security Survey module and its importance in understanding the causes and consequences of food insecurity. It was launched by the USDA Economic Research Service in 1995. It's applied annually through the Census Population Survey and via rapid monitoring system. It's based on a strong consensus definition and sound conceptual framework, which is the topic of the next presentation. And it was informed by valid experience-based measurement scales developed in the 90s, mostly in response to the government denial at the time of the continuing presence of food insecurity in the country. The US Household Food Security Survey module, in short, has confirmed the still widespread presence of household food insecurity, its nature as a social determinant of health, the fact that there are major socioeconomic, zip code, and ethnic racial disparities in food insecurity, and the fact that household food insecurity has very negative impacts on mental and physical health in children and adults. However, we still know little about the direct relationship between household food insecurity among persons affected by cancer, which makes our webinar of today very, very timely. Next, please. If you want to learn more on the history of the US Household Food Security Survey module, I recommend that you do the reading of this report from a major event organized by the Economic Research Service to celebrate the 20th anniversary of this measuring tool. So in conclusion, the discovery, quote unquote, of widespread food insecurity or hunger in the 60s led to the first and only White House Conference on Food, Nutrition, and Health. The legacy of this conference is enormous. As I have just shown, The Household Food Security Survey module has been able to keep food insecurity in the political agenda. And it is very important that in the next talk, we all listen carefully to the definition and the conceptual framework that guides this measure in the US. Again, little is known about how food insecurity affects not only people who are experiencing cancer, but also their family members. And at the end of the day, if we can go to the next and last slide, let's all make sure that today's webinar will help us think collectively how to have a more just food system surrounding people affected with cancer and their families. If you can go to the next slide. The next one, please. Yes, thank you. And this is the end of my presentation.
Well, Rafael, thank you so much. That was fantastic and a fantastic big picture sort of overview. Stacy, if you're ready, you'll take us through the conceptualizing of food insecurities.
Thank you. Just pulling up my slide here. Okay, and I trust that you can see my slides now. I also so grateful to be with you all on such an important topic, and I'm especially appreciative to my colleague, Dr. Ann Jackson, who encouraged my participation today. Thank you, Ann. My work, I'm a physician scientist, and my work on food insecurity would be at the far translational end of the spectrum, in part with the support of a Healthcare Innovation Award from the US Centers for Medicare and Medicaid Services. This innovation award required innovators to deliver back to society a sustainable business model, and my disclosure slide became much longer than it ever was before. I also want to acknowledge the National Institutes of Health, many institutes supporting work I'll share today. So the US Department of Agriculture gives us this simple but important definition of food insecurity: the limited or uncertain availability of nutritionally adequate and safe foods, or ability to acquire acceptable foods in socially acceptable ways. And of course, as we'll hear throughout the discussion today, food insecurity and hunger are overlapping concepts. Most human beings can relate to hunger and the symptoms associated with it. But the term food insecurity from USDA is a state, not a trait, and people can move in and out of the state of food insecurity. The measures, which we'll hear more about also later, allow us to identify the severity of food insecurity, and people can move in and out of more severe and less severe states. Feeding America gives us food insecurity trends and projections, and we typically see higher food insecurity rates among children or households with children, as we see in the green as compared to the orange overall line. The data just before the pandemic indicate food insecurity was on the decline. Of course, this condition fluctuates with economic conditions more broadly, but projections are that food insecurity rates are now going down, probably in response to some of the pandemic-related policies. But disparities persist, and these data also from Feeding America show us significant disparities comparing African-American or Black individuals to white individuals, and the data suggest if we also could look by Latinx or Hispanic status, we would see even greater disparities by race and ethnicity. We'll hear more from Professor Seligman, whose pioneering paper in the New England Journal of Medicine 2010 helped doctors and other healthcare professionals internalize an understanding of the ways in which food insecurity drives health and health outcomes. This mechanistic understanding is extremely useful as you think about this work going forward, and reminds us that constrained dietary options can drive both compensatory behaviors in times of adequacy and in times of food shortage that can have different but mutually reinforcing effects, especially on metabolic diseases. These metabolic diseases present competing demands for how to spend self-care time and dollars on medicines, can impair self-management, resulting in conditions that can then drive food insecurity. So we see this positive feedback loop. And stress, psychosocial stress, and physiologic stress contribute to the ways in which food insecurity drives important health outcomes. In consulting with Professor Seligman before the talk today, she pointed me to this perhaps simplified illustration of the interwoven pathways connecting food insecurity and poor health. And both of these papers are required reading for work in this area. The evidence since the 60s continues to accumulate, but there is strong evidence linking food insecurity to poor health outcomes, physical and mental, for children, for adults. I'm an OBGYN, and of course, unfortunately, for pregnant people and their fetuses. So when we think about the relationship between cancer and food insecurity specifically, we may be inclined to think first about the unidirectional relationship, the ways in which cancer itself might drive food insecurity. And of course, there are some important mechanisms here. We can think about the direct and indirect costs. Of course, cancer, direct costs of time. Cancer can be like a job. I take care of women with cancer almost exclusively in my clinical practice. And women do talk about cancer as their second or third job. The cost of treatment, the limit on affordable and nutritious food in cancer care sites where people with cancer spend a good part of their time, and the indirect costs. And I think an underappreciated mechanism linking cancer to food insecurity is the social isolation of cancer. But of course, we can imagine important mechanisms whereby food insecurity itself may intervene in cancer prevention and control activities and initiatives. So, building on Professor Seligman's model, of course, we know that food insecurity can drive chronic disease. Some people smoke as a way to suppress appetite or the uncomfortable sensation of hunger. And we know the causal relationship between smoking and cancer. There is evidence that girls and women in particular who are chronically food insecure may transact or trade sex for food. And this increases the risk of sexually transmitted infections like HPV, HIV, hepatitis that can also be risk factor for cancer. A delay in symptom recognition. And severe food insecurity, the symptoms of wasting, of cachexia, of hunger may obscure symptoms of advanced cancer. And then of course, food insecurity is cognitively taxing. It can make it difficult to adhere to care, to understand complex decisions related to care. And one paper of ours looked at access to survivorship and self-care resources, which was lower in communities where food insecurity was highest. And we can't talk about the relationship between food insecurity and cancer without acknowledging poor nutrition that can come with food insecurity. But there are some specific mechanisms that link cancer to poor nutrition, and these can vary depending on the cancer type. But commonly, patients undergoing systemic chemotherapy will complain of a loss of appetite, a change in taste and olfaction that can affect eating. Gastrointestinal side effects are very, very common. Head and neck cancer patients might experience difficulty with chewing and swallowing. And then there are the psychosocial changes in eating habits, that social isolation, and psycho-emotional and physical stress that can contribute. And we know the relationship between poor nutrition and cancer susceptibility, perhaps through immune compromise or immune modulation. Just drawing on a comment from one caregiver of a patient at the University of Chicago who was able to receive food from our food pantry system, which Ann Jackson has helped to champion. We come all the time. My husband has cancer. We're so grateful for this food. I only work part-time, so thank you very much. So if we're wondering, is there evidence that time and money are reasons that cancer might drive food insecurity? Here's some qualitative evidence. We've been studying food insecurity at the University of Chicago now for several years. Of course, these are single site data, but they really align with what we see on the national level. Rates are higher in our community. But I wanted to call out the concept of hospital food insecurity, a concept that Jennifer Makalarski, an epidemiologist in my lab, wrote about in the American Journal of Public Health. In our hospital, parents and caregivers were surveyed about food insecurity, and more than 1 in 10 indicated food insecurity solely solely as a consequence of their child's hospitalization. So this reminds us that food insecurity is a state. There can be episodes, and then you see another 1 in 5 who were experiencing both household and hospital food insecurity. Over time, the rates haven't changed too much, unfortunately. And in 2019, pre-pandemic, we saw a rate of 26% in our cancer population. I'm sharing some unpublished data with you because I understand that there are very scant data to help us understand the prevalence of food insecurity in the cancer population. So there's always some risk at sharing pre-published data, but take these with a grain of salt, but I think they're informative. Here we look at 2 cancer populations in Chicago and New Haven, Connecticut, with Carrie Gross at Yale and the Siren Group at UCSF. And what we see are overall rate of food insecurity in the 25% range, but much higher rates in the African American Black people and other people identifying as something other than Black or white. And we see higher rates among women with cancer versus men. Here are data from a national survey of 3,200 women in the US. We looked in April 2020, the first month of the pandemic. And you can see just by looking at the colors that women with cancer, people who had had a cancer diagnosis in the last 3 years, much more likely to have not only food security, but every other health-related socioeconomic risk surveyed. And the rates of interpersonal violence are really high. These are unadjusted estimates. And when we stratify these 62 women with cancer by race and ethnicity, here only looking at white versus other women, we see the same patterns as we've seen in other studies, but 88% of not white women with cancer indicating food insecurity in the early phase of the pandemic. So lastly, I was asked to conceptualize food insecurity, and I gave you a definition, but I think it's important to remind ourselves that this is a very stigmatizing condition. Interventions, in my opinion, have largely focused on feeding versus fueling, helping to fuel people so they can live their fullest lives. Our approach has been a no barriers, no prescriptions, no questions asked approach. Here you see one of our pantries in our retail cafeteria, to our knowledge, the first of its kind. And people are invited to take food for themselves or anyone they know, and to not only receive, but to give. And that'll be my last point. Here's a letter published in American Journal of Public Health with our first paper on this topic, a letter from a caregiver, a parent of a child with cancer in our children's hospital who had been participating with Feed First the whole time the child was there having radiation, giving, finding meaning in giving food, even though they were also caring for their child with cancer. And I think this is an idea I hope will carry through our conversations. Thank you so much.
That was great. And thank you so much. That was really informative, and looking forward to sort of questions that will come and follow. The next presentation we have will be that of a video from Francesca Gainey, who will talk about research and surveillance needs. And so I think Rachel, or Emily, you'll fire that up.
I'm really happy to be here today to have this conversation about food insecurity and cancer and our surveillance and research needs. I direct the Food to Overcome Outcomes Disparities research program at Memorial Sloan Kettering Cancer Center as part of the Immigrant Health and Cancer Disparities Center. Our mission at the Immigrant Health and Cancer Disparities Center is to promote health equity for immigrant, minority, low socioeconomic status, and other underserved communities. And we do this through research, outreach, patient and community engagement, service delivery, training, and program and policy development. And these are, of course, all interrelated. We use a social determinants lens in all of our work. And our food insecurity research is so important to us. We have just seen way too many people who have to decide between feeding their families and or getting cancer care, and we can't let this continue. So when thinking about food insecurity research, we recognize that we have to understand the contextual factors that underlie this food insecurity. So our food insecure cancer patients oftentimes are also experiencing financial toxicity from their cancer treatment. So this also needs to be addressed and researched. And then they have a baseline socioeconomic status that might predispose them to their food insecurity and cancer treatment. And this is also something we need to be thinking about and addressing as we move forward with our food insecurity agenda, as well as the food systems in the US and how these might contribute. Our research stems from our awareness that cancer patients who are food insecure are suffering, especially because cancer patients often have increased nutritional needs. We know that their treatment-related costs and their income loss contribute to the financial toxicity of cancer treatment, which goes hand in hand with food insecurity. Food insecurity leads to poorer functional, emotional, and social well-being and higher depression risk. And we know that food insecurity leads to care delays, cost-related medication non-adherence, and these in turn lead to poorer outcomes. So it's vitally important for us to screen for and address food insecurity in our cancer patients to improve their cancer outcomes and decrease cancer disparities. And at the same time, this screening that we need to be doing of our patients needs to be turned into action and into interventions to address food insecurity. So we think about food insecurity with a multi-pronged approach to both surveillance and actionable research. We know it's important to have population-based surveillance and then this individual patient and family screening for food insecurity. We need to be working on research around interventions for food insecurity and looking at outcomes, effectiveness, and costs of these interventions, and then scaling them up through a dissemination and implementation research process, and looking at program policy development and the research around this. And these approaches really align well with the NIH 2020 to 2030 Strategic Plan for Nutrition Research and with the NCI Healthcare Delivery Research Program's financial hardship priority areas. So we need to be harnessing the power of population-based data sets to do really great financial security and insecurity of food security and insecurity surveillance. We have a number of national surveys that ask about food insecurity and cancer, and researchers are starting to mine these. We need to be sure that these surveys go out in the correct languages of patients and that they work for patients no matter what their literacy levels are. We need to be looking at state and local surveys, which often also include information around food security and cancer, and at hospital discharge research data sets, such as the New York Sparks data sets. Cancer registries, we know there are issues with capturing complete information in cancer registries, but if all cancer registries were capturing food insecurity information, we would have an incredibly important set of data sets to look at cancer outcomes because there's so much detail about patients' cancer treatment and their courses and their outcomes in cancer registries. Insurance data sets could be a wealth of information, as could information that we could glean from cancer providers and research consortiums. We should have a food insecurity mandate for these centers and these consortiums. This could really increase our awareness of food insecurity in cancer patients, on outcomes, and on the impact of these important interventions which need to be developed. So patient and family screening, in addition to helping us to provide better care by getting these data, we can really learn about the impact of our interventions. So we know we should be screening all families and patients at baseline. Over 10% of the US population, US households are food insecure, and this is much worse in underrepresented communities. In New York City, we found that New York City safety net cancer clinics had their patients had a 56% of the patients were food insecure. In comprehensive cancer centers, 18% to 30%. It is so prevalent, and we need to be documenting this. This, of course, this was pre-COVID. This, of course, significantly worsened during COVID. There is an increase in interest in assessing all patients with social determinants and essential needs assessments. So we need to be including, as are included in these assessments, a 2-question food insecurity screener. This will be quick and simple. We should be studying the impact of digital assessment with patients, and then resource linkage tools. When food insecurity is assessed, we should be able to automatically link patients with food resources. We should be thinking about using patient portals. They are becoming so much more commonly used among our patients and institutions. But we should be aware with this that language and literacy considerations might marginalize the very patients we want to reach from the portal. These data could then be included in the EHR, and then we could flag those patients who are food insecure and need special attention in this area. And we should be conducting ongoing food insecurity screening throughout the cancer journey, which is often not done at cancer centers, even when they do an initial food insecurity assessment. We need to be studying how often this screening should be conducted. We need evidence to inform this practice. And these data will really help us to inform our interventions and drive program and policy development. So we need to systematize our outcomes data collection, so that includes nutrition status, biometrics, patient-reported outcomes, cognitive outcomes. We know that food insecurity now, there's evidence that it might be associated with poorer cognitive outcomes. Outcomes such as treatment adherence and completion of course, and then survivorship care, and thinking about issues such as ongoing cancer screenings that are recommended once patients complete treatment, and how food insecurity might impact whether or not patients get these. And then treatment and improvement of comorbidities, which we know go hand in hand with food insecurity, such as obesity and diabetes, and then of course, survival. And we need to link our food insecurity data with these outcomes data, and then look at interventions for food insecure patients and how this changes outcomes. So we need multi-level intervention research, including dissemination and implementation research that looks at patient and health systems level interactions that address food insecurity prevention, and then of course also treatment. I talked about digital solutions, but of course be aware always of the technology divide. And food provision interventions, which are becoming used more often, are really important, and we need to be documenting the impact. We, for instance, conducted a 3-arm randomized controlled trial of hospital-based nutritionally tailored food pantries, food vouchers plus the pantry, home grocery delivery plus the pantry, and found a statistically significant improvement in treatment completion with the vouchers, and in patient-reported outcomes such as quality of life and the PHQ-9 with home grocery delivery. And we need to be doing more research like this and scaling it. And then doing D&I research to find out how to take these interventions and really make them work across a variety of settings. Addressing financial toxicity, doing research into that, really important for food insecurity. And then interventions such as a guaranteed minimum income for cancer patients. And this exciting work is being done right now at the University of Pennsylvania. Meredith Doherty is starting a study to look at guaranteed minimum income in cancer patients. And we need to be looking at costs while engaging all stakeholders in the process to make sure that we're getting everyone's voices, patients, healthcare systems, and policymakers, for instance. Our policy research should look at prevention and interventions once somebody is food insecure. I really want to advocate for multi-agency food insecurity and cancer policy research working groups, where we bring together the key players whose work touches on this issue, and encourage mathematical modeling of policy interventions, their impact on outcomes. For instance, what happens if we increase SNAP benefits? What would happen with our food insecurity rates in our cancer patients and on their outcomes? And these SNAP benefits should be inclusive of immigrants of all statuses. What if we tagged emergency Medicaid enrollment with a food voucher intervention program? And we modeled this and looked at how we would affect costs, but also outcomes for our cancer patients. What about the guaranteed minimum income for cancer patients if we mathematically model that once we know some results on the impact? And then we need to be modeling changing our food systems to address food insecurity for all individuals, but especially for our cancer patients. So thank you so much for your attention. This was just a brief discussion, of course, of how we should be thinking about, how we can be thinking about surveillance and research. And I really would look so forward to the next steps where we all put our heads together to make an impact. Again, nobody should be deciding, of course, between feeding their families, getting their treatment, having enough money to get to the cancer center. And we can really work to address this, and the research will be so important, as will the surveillance. Thank you so much. I also want to thank our dedicated food team, which works tirelessly to address food insecurity in our cancer patients. And I would also like to thank our funders whose support of the research in this area has been so important for our patients. Thank you.
And thank you. We will, the next voice you'll hear will be that of Shanta Chambers from the Patient Advocate Foundation. Shanta is going to address the issue around patient advocacy strategies to address food insecurities. Shanta, you're next.
Well, thanks so much, Dr. Nguyen, and special thank you to both you and Gwen for this invitation today. And you actually can go to the next slide, Emily. So for over 25 years, Patient Advocate Foundation has been at the helm of addressing access and affordability barriers for patients living with a variety of chronic and complex health conditions. Today, we support patients with over 600 different diseases. And as we interface with patients, we realize that there are many factors at play contributing to the barriers that they experience. However, for many of the limited resource patients that we support, it's actually the various social determinants of health at play that are really creating the social and financial need gaps that far exceed the, of course, as we noted, the resources available to support all of them. Next slide. So of course, as unique as the patients that we experience, so is the community that they represent. So the one thing our experience has really taught us is that to find tangible solutions, that you have to approach one patient at a time, because just as inequitable as the impact of cancer is on people of color, low-income individuals, those living in rural communities, so are these other factors at play, including food insecurity, which has also been highlighted by my previous panelists. Next slide. So when we talk about the equitable impact of cancer and food insecurity, I think it's important to do a side-by-side. So on the left, we actually look at who are those population groups that are most likely to be inequitably impacted by cancer. And when we do that parallel to the 5 characteristics of those most associated with the likelihood of experiencing food insecurity, we see that there are some commonalities. There are things around low household income, education, limited social networks, being unemployed, and even location, so food deserts. So there are some commonalities when you look at the characteristics by both of these population groups. Next slide. So when we begin to look at things through this, equity lens, it forces us to acknowledge that food insecurity is not a singular event, which has already been pointed out, nor the consequence of one singular action, which was pointed out in our opening panelists. Instead, what it allows us to do is examine the many contributing factors that cause and exacerbate food insecurity, that when we group them together, we actually call them the social determinants of health. So even as we examine the social determinants of health, we have to understand that for each social determinant, there is an underlying political determinant that has either a historical and or a present day context that we must address. Hunger is a social determinant. So we have to ask ourselves, what are those underpinnings that continue to drive this determinant, resulting in continuous populations of individuals that are food insecure? That means in order for our efforts to address food insecurity to be sustainable, we must apply both an upstream and downstream strategy, which will also be highlighted in a later presentation. Next slide. So when we say the social determinants of health, what are we really talking about? So the social determinants of health are those non-medical factors that influence health outcomes. So just as we know the factor that contributes to inequitable cancer outcomes, I think we have to acknowledge that the same holds true when it comes to food insecurity. As such, that's when framing around the pillars of equity become critically important because it forces us to not only think about the equal distribution of resources as the primary solution. That's basically the definition for equality. But what equity does, it provides the opportunity to figure out how we meet people where they are and in a manner that responds to their very specific and unique needs. The equity frame allows us to take into account the social context in which people live, and it is a critical factor that must be accounted for, especially when it comes to food insecurity. The social context is critical because it drives and it helps us understand what people have access to and what is available to them in their respective community. Because we can no longer make the assumption that availability means accessibility. This lens of equity helps us uncover the barriers that may be in place within the context of one's community. Next slide. So one of the other presenters pointed this out, and I really want to underscore this here. And this is basically a report that really talks about health outcomes that are attributed to medical care, the percentages that are attributed to genetics and behavioral health, but also the contribution of the social and physical environment to healthcare outcomes. Again, it underscores the importance role that social determinants are playing in an individual life. And as the second resource pointed out, negative social determinants can have an impact on one's ability or knowledge around healthcare and the resources and how they access them. So I often will say that just because an individual doesn't know, it doesn't mean that they don't need. We can no longer make the assumption that people know how to connect to the resources to respond to their need. As an organization who's been in this space of helping to connect people to resources, that is how we approach the project that I'm going to be sharing with you in the next slide. Next slide. So we had a great opportunity to partner with a phenomenal organization, Team Rubicon. And we were afforded this opportunity as a result of some funding provided by the Bristol Myers Squibb Foundation and this was in response to, of course, COVID, and more importantly, address this issue around food insecurity. And so what this was an emergency food assistance program. The program specifically focused on individuals who are living with cancer, multiple sclerosis, or rheumatoid arthritis. However, for the sake of our talk today, I'm only going to show a couple of things, specifically from our survey data, the impact of these types of interventions, specifically on African-American individuals. So this partnership with us and Team Rubicon and the support of Bristol Myers Squibb Foundation allowed us to have a two-directional approach to actually addressing food insecurity. We realized that number one, we couldn't just have an intervention that solely focused on food deliveries because we realized that even though Team Rubicon has a whole host of their gray shirt volunteers across the country, we didn't want to run the risk of not being able to connect people where volunteers may not exist. So we had to complement this with a food grant program. So an actual financial grant program that provides grants to individuals so that they could actually access food in their respective community. but it was the uniqueness and it was the experience of both of us organizations, or both of these organizations coming together, bringing our skills, bringing our experience, bringing our capacity together to respond to the needs of those who had been identified. So this program ran from May to October of 2020. As I pointed out, it was a combination of direct food assistance grants. So these were grants in the amount of $500 that were allocated directly to individuals, and complementary food delivery programs. As a result of this partnership, we were able to accomplish over 1,100 food deliveries and serve nearly 23,000 people with direct grants. Next slide. So not only did we want to really talk about the reach of the program, we wanted to do some surveys to really understand the impact. And so these next 3 slides are just going to give you some high-level summary of the impact. This gives you basically some demographics. And here I just want to call out, when you look at urban and suburban, right? There's the assumption that in an urban or suburban community that people have access to everything that they need. And so when you account for those types of resources being available, what we see is that they may be available, but they're not accessible to everyone. Next slide. So this slide really points out, specifically, we asked a question around if they had trouble locating any of these things. And as you can see, bolded in navy blue, on the slide to your left, you see groceries and food delivery. And on your slide to your right, did they have trouble paying for these things? Food ranked out #1 in terms of the one thing that people had the greatest challenge or trouble actually paying for. Next slide. And then we begin to ask them, had they sought out any type of charitable grant program? Again, trying to understand if people know how to identify and connect with resources. And so you'll see that many have pointed out that they had actually sought out charitable grant programs other than those from PAF. And we also wanted to understand those who actually tried to seek support from food banks. And you see that breakdown here. What I really want to point out is the 54% that did not seek any help, because I think it's important for us to understand, if these are individuals who identified food insecurity, why didn't they seek out help? Was it because they did not know how to, or were there other contributing factors? Next slide. So I really want to close here with this. You know, the impact of food insecurity is, of course, not non-consequential when it comes to cancer outcomes. If you take a patient who's in treatment and part of their treatment recommendations includes consumption of fresh vegetables and fruits and other nutritionally adequate foods, and don't take into account that the patient does not have access to these items, there can result in uncomfortable treatment experiences, as already pointed out, that could impact a patient's ability to adhere to treatment. So it's not because they don't want to, but because the one thing that is critical to their treatment is missing or not available in the dosage that they need. We talk about food as medicine, but we realize, just like some of our greatest innovations, they're not available to everyone. And that also holds true to nutritious food. So the patient is not non-compliant, non-adherent. The patient is stressed, the patient is financially strained, they're emotionally exhausted, and they are hungry. So as we think about this, our tangible efforts will require both upstream and downstream, so that we can really begin to make this whole issue of food insecurity a thing of the past.
Thank you so much, Shanta. That was fantastic, as always. Some amazing information that you just gave us. We're gonna, the next voice you'll hear will be that of Hillary, who will be talking about the policy levers to address food insecurities. And whenever you're ready.
Great, thank you so much. I'm really pleased to join a phenomenal panel, and my section of this is going to focus on policy levers to address food insecurity among patients with cancer. And I really want to thank the panelists who teed up this discussion perfectly. I want to start with us reminding ourselves of the difference between a social determinant of health and a social need. We think of social determinants of health as fundamental drivers of the conditions in which people are born, grow, live, work, and age. And these fundamental drivers that we've discussed previously increase risk across a number of different chronic diseases, including cancer. It really does focus on the root causes. A lot of what we are talking about today are ways in which health systems and clinical settings have been increasingly invested in addressing a social need. And a social need is a downstream manifestation of the impact of the social determinant of health. So for example, the social determinant may be food insecurity, and your acute need may be for food today. And I want to call attention to the fact when we talk about this from a policy perspective, is that the interventions to address these social needs are often Band-Aid solutions, or some people would argue they are always Band-Aid solutions that are intended to address a problem that wouldn't have occurred had we done a better job of addressing the social determinants of health. And ultimately, we want to be addressing the social determinants of health. Now, with this caveat in mind, I want to start this presentation by thinking about what the conceptual model is for screening people for food insecurity in the clinical setting, and then doing something about it to try to fill the acute social need if a need is uncovered. And we often shorthand this process as screen and intervene. We screen for food insecurity in the clinical setting, and then we intervene in some way. And in most cases, this is the conceptual framework that we're thinking about when we are thinking about these models. We do the clinical screen. If you screen positive, we refer you to some person within the clinical system or within the health system who can make a connection to a program. And once you connect with that program, you enroll. And those programs may either be happening on site, as a number of different of our panelists talked about, like Dr. Grini and Dr. Lindau. They may be referring out into the community for a community program, or they may be referring into a federal food program. And the idea is that these programs would improve diet quality, food security, and clinical satisfaction, and that would result in improved health and improved utilization, and ultimately improved patient outcomes. Now, in truth, these second and third box, the referral to someone who can make a connection to a program, and then the enrollment, has turned out to be very, very challenging. And a lot of our policy solutions are going to focus on trying to figure out how to better address those challenges. But in order to do that, I have to give you a little bit of an understanding of what is the ecosystem for what we can do about it if we screen our patients and they are positive for food insecurity. So just some examples of what this ecosystem looks like. A number of health systems over the previous 5 to 10 years have invested in on-site programming so that patients can seek resolution to their acute need while they are in the same geographic space as the clinic. So this would look like a food pantry in the clinic, as Dr. Lindau showed us. It may look like a mobile food distribution outside the clinic. So for example, a truck from the food bank coming once a week that's stocked with foods or perishable goods. And it may look like embedding an eligibility worker for federal nutrition programs in the clinical setting, for example, in the hospital. This would look, for example, like supporting patients while they're in the hospital with enrolling in SNAP. SNAP, as Raphael discussed, is the Supplemental Nutrition Assistance Program, formerly called the Food Stamps Program. There's also a world of community programs out there that have become really key partners in the intervene part of screen and intervene. And these include medically tailored meals and medically tailored groceries, oftentimes delivered to the front door of the patients, food banks and food pantries, and then produce prescription programs, which provide a voucher or a debit card for food that can be redeemed at a farmer's market or a retail grocery store. And then there are a host of other federal nutrition programs, SNAP being by far the largest, but WIC also being available to support pregnant and postpartum mothers and children under the age of 5. Now, in general, we call those on-site programming and community programming food as medicine interventions, roughly speaking, although you can certainly argue that WIC is also a food as medicine intervention because it's so highly integrated with the healthcare setting. In general, a food as medicine intervention provides access to food for priority populations that often include food insecure populations and populations with chronic disease, and they are tightly integrated with the healthcare system. And so the question is, what policies can support the implementation or the impact of these programs? And in particular, we are asking our policies to support what I see as a couple of key challenges in food as medicine interventions. The first is that they are often funded by short-term grants that someone has to keep rewriting. And there's a lot of energy being spent in the field in rewriting grants to make sure that programs stay sustainable. When they are implemented as part of the healthcare system, they're often implemented with the goal of demonstrating a return on investment, rather than a goal of demonstrating improved clinical outcomes or an improved patient experience, or God forbid that addressing someone's food insecurity in their own right would be a sufficient outcome for many of these programs. Access through these programs is often for a limited amount of time. For example, you may get access to a medically tailored meal program for 6 weeks after discharge from the hospital, or you may get a produce voucher to be used for 3 months. And that may not be an adequate duration to really support patients with cancer. When we are referring people into the social safety net, we're referring them into a system that is very fragmented and is often inadequately funded. And so it's a very complex system for patients to navigate. And finally, priority populations often change. So your intervention may have cancer patients as a priority population this cycle, but next cycle it may be patients with diabetes or patients with HIV or a different priority population. And so what policies move us toward a better system? Well, the first policy I want to mention has been mentioned a little bit today. This is a little p policy rather than a big P policy, but it's implementing universal screening programs for food insecurity. You cannot identify a food insecure patient by looking at them, and physicians and other healthcare providers are often very surprised to hear which of their patients are food insecure. The hunger vital sign is the 2-item clinical screen that is most commonly used, and it is embedded already within the electronic health records of many off-the-shelf social determinants modules. And it asks patients to identify whether these statements were sometimes, often, or never true for you and your household in the last 12 months. Although there are some discussions about changing those options to yes, no options in order to support even more rapid clinical screening. So in terms of on-site programming, I'm going to mention 2 important policy levers. The first is to transition funding from healthcare systems to on-site programming away from the community health needs assessment process and short-term financial foundation funding, and towards longer-term, more sustainable funding like that could come from general operating funds. This means that people spend less of their time on rewriting grants, and they are less subject to to changes in priority populations, and that creates more stability for these programs. Another example of an important policy lever for on-site programming is streamlining the co-enrollment of SNAP and Medicaid, or SNAP and other benefits. In most states, SNAP eligibility criteria and Medicaid eligibility criteria are very similar, and supporting patients to enroll in both programs at the same time, as is already done in some states, can really make it an easier system to use for our patients. In terms of policy levers for community programs, again, we're really focused on sustainable sources of funding. And at the state level, what this has often taken the the form of is waivers to the federal government to allow Medicaid dollars to be spent on community programs that provide food, most commonly home-delivered medically tailored meals. There are also a number of federal proposals that have to do with pilot projects. There have been expert support for adding funding for medically tailored meals and medically tailored groceries to the Farm Bill to provide some longer term, more sustainable funding. And there have been suggestions that we should expand the produce prescription program that is already in the Farm Bill as part of what is called the GusNet program, or the Gus Schumacher Nutrition Incentive Program. This GusNet programming already funds about 20 produce prescription programs across the country and is adding new grantees every year. Other examples include implementation of nutrition policies in the food bank and food pantry systems, so that when we refer patients out into the community to a food bank or food pantry, we are assured that what they get from the foods they get back are healthy and nutritious and support cancer treatment rather than work against it. And more federal, state, and local financial support for food banks to purchase a healthier basket of goods to provide through their system. In terms of policy levers for federal nutrition programs, there are dozens and dozens and dozens of policy levers. So I'm going to bucket them into 4 approaches. The first approach is to expand access to our federal nutrition programs, and coordinating SNAP and Medicaid eligibility is one way to do that. Changing the income threshold for eligibility is another way to do that, particularly among cancer patients who have higher out-of-pocket healthcare expenses and who really may need that additional buffer. The second bucket is ensuring adequate benefits. Benefit levels in 2021 are tied to what the USDA calls the Thrifty Food Plan. This is the lowest cost food plan, and it is not adequate to cover a healthy diet for most people in most situations. There's also streamlining enrollment and re-enrollment, so it is easier for people to get into the programs in which they're eligible and to re-enroll. And facilitating redemption, which right now is a lot focusing on online redemption, which allows people who are recovering at home to not have to make trips to the grocery store. And finally, I just want to end by, I just want to end by one last slide on how might healthcare address food insecurity as a social determinant of health rather than a social need. And the first is to implement what we call anchor institution initiatives. Anchor institutions are institutions that are firmly rooted in their local community and play a very important role in the local economy. And this is hospital systems are anchor institutions, and they commit through these initiatives to leverage their economic power, their human and intellectual power to improve the long-term health and social welfare of their communities to really get at the social determinants. And finally, they have an enormous amount of weight to throw around in terms of educating policymakers and decision makers about important changes to our policies. So for example, when a health system supports changes in SNAP that support enrollment and better benefits, that makes a big difference. We need health systems and clinical systems to be educating policymakers about this. Thanks very much.
Hillary, thank you. That was fantastic. And as I think many of us are getting the sense of, you know, the last time we talked about anything that's significant around food insecurities at the White House, we said was back in the 60s. I mean, the reality is we're just really scratching the surface, I believe, of something that COVID has shown us is incredibly important. So I think this is hopefully the beginning of many other conversations around this incredibly important topic. I'm going to invite Gwen Darian, who will be my partner in crime in getting through this panel session. But if Jessica, Dorothy, Macy, and Kristen could join us now, I think I'll have our panel just the way this is going to go. is that we'll have the panelists sort of just, and Gwen will say a couple words, and we'll have the panelists just introduce themselves, and then we'll start with the questions. So Gwen?
Great. Thank you, Rob. There were so many thoughtful and incisive comments throughout all of the different panelists. And I just wanted to highlight a couple of things that I hope that we can address and think about as we're going through the panel. One of the first things I wrote down is this idea that Stacy Lindow said a couple of times during her talk, that food insecurity was a state and not a trait. And that relates back to what Raphael was talking about when he talked about the idea of discovering food insecurity in the late 1960s. Then we were talking about the difference between social determinants of health versus social needs, and the concern that some of these things were just a Band-Aid rather than a really systemic and structural change. The other thing I was really kind of taken by is Shanta, my friend and colleague Shanta Chambers' discussion of this through an equity lens. And I think that's been the sort of subtext and implicit in everything that everybody else said. And Raphael also started with that. But I think it's a really critical point that when we look at this panel, that we look at it through an equity lens. So I'd like to invite the panelists to introduce themselves and say a little bit about what their perspective is, both in personal and professional, about food insecurity, how they've experienced it, and how they've experienced not just raising awareness of it, but also in the effort to eliminate food insecurity. So first, I think we have Jessica Birch.
Hi, thank you so much for including me in today's panel. I am a registered dietitian and a research project manager at Community Servings in Boston, Massachusetts. We provide medically tailored meals to the critically and chronically ill members of our state that apply to our program. And I have been working here for almost 2 years, first as just a registered dietitian, and I shouldn't say just as a registered dietitian, but my role has expanded into looking more at the research, into the research realm, looking specifically at how we can address food insecurity for individuals by using medically tailored meals as a model for addressing that. And so that, that's kind of a quick summary of what I've been doing now. I've been working in clinical, as a clinical dietitian for the past 8 years in community health centers throughout Boston. And this has been kind of at the base of my work since I started. So thanks for having me.
Thank you. Dorothy Johnson.
Hello, everyone. Okay, my name is Dorothy Johnson. I am a 12-year breast cancer survivor. And just listening to the different speakers and presenters, 12 years ago, I had no idea that these programs were offered. And I'm quite sure nowadays in different areas, hospitals, a lot of people still don't have the information there. And while I want to say Francisca was speaking, it came to my mind, in the doctor's offices, they have all these literatures about cancer, this, that, and other, but never about food equity. So as I shouldn't say now, but back then they did not have it. So now I'm saying, well, maybe that's another pamphlet that could be put into different doctor's office so that people will be, the cancer patient will be aware of that. It's just, when you go as a cancer survivor, when you first diagnosed, you don't think about food and everything. You think about the process of going through getting to A to Z. and never the food part of it at all. Like you said, some people just don't know what to eat. If also there was, I know nowadays they have nurse navigators. So my granddaughter is also a 3-year survivor. And I saw way more material when I went with her than I did when I was diagnosed. So I think more so getting it out, the word out to people that these programs do exist. And it can really help out a lot of people, because once again, with COVID and being diagnosed recently with cancer, you know, they're not even thinking about this, just try to get over the hurdles of everything. And that's who I am.
That's great, Dorothy. And we'll also talk about that later, because it is about treating, it's about helping, it's about health, it's about framing it as health, not just as clinical care. And that is a inseparable part of getting to health. And I'm a 3-time cancer survivor, so I have many stories about food and cancer, and also trade-offs. And I think that was the other thing we really talked about that was brought up earlier, was this notion of trade-offs. And we see that all the time, where people choose between between taking their medication or following the care plan that they've developed with their healthcare provider, and feeding their family. Or they do things like, you know, they don't talk about that. They think that all they're supposed to talk about is their disease, but they don't realize that returning to health and being a survivor means that you're talking about the whole person.
I agree with you.
Excuse me. So now we have Macy Mears.
Yeah, hey, thanks for letting me join. So my name's Macy. I'm a registered dietitian at the University of Chicago. I work specifically with the pediatric population only. I do several different populations, but within that is our inpatient oncology population. And so I think just listening to all of this, obviously I'm bringing the more clinical and inpatient side of treatment. But with patients, I get to know them very well, right? Because we come back into the hospital for treatments. And so I think seeing food insecurity is very common, because what's set up in the hospital is much different than going home. And it's really, for so many of my patients and their families, it's just focusing on one day at a time, because that's all you can do really when you're going through a treatment and you have other kids at home and you're balancing work and trying to stay with your child in the hospital. And I do think just from the inpatient side, I'm just going to put it out there, I think it's really an important thing to think about, and what I see all the time is patients who might not be eating orally, right? Like through a tube, and how that's covered and can be so accessible. And yet when we deal with food and just like eating healthfully, that's not always as dependable, which I just think is huge and is an important topic to discuss. Anyway, so that's who I am.
Great. Thank you, Macy. And I think the other thing that we have to continue to keep in the forefront is something that Shanta mentioned and Dorothy mentioned, and it's been mentioned before, which is that people aren't aware of the programs that are out there. And there are fewer programs than the need that's out there, but people don't even realize that there are programs out there that can help. But again, they address social needs. They don't address structural change. So I think that's the other thing that we're looking at, is how do we change from awareness to elimination? And it seems like there is awareness, but there is not, we certainly are so far from eliminating food insecurity. And then Kristen Sullivan.
Hi, everyone. I'm Kristen Sullivan. I am the Director of Nutrition and Physical Activity at the American Cancer Society, based in Atlanta. And I am a public health nutritionist, so I kind of come to this issue from more of a population level and kind of a systems change approach. And, you know, we do a lot of work with health systems. At the American Cancer Society, we're really set up to work with our health systems partners on a number of systems change, including increased screening, but also provider education around nutrition and physical activity. We work with comprehensive cancer programs in states, many of which are trying to address issues of food insecurity as part of their comp cancer programs and providing training and technical assistance to those programs. So I'm happy to be here and thank you for having me.
Great, and thank you guys. I think we're gonna open up with a couple questions, and the first one may be a little bit of a curveball, but I'm gonna ask it anyways. So as you talk about food insecurities, and you guys have been describing it, we've been talking about it all day, does it look different, rural versus urban underserved versus suburb versus, other places? So, I mean, or is it just one common theme? And the second follow-up question, and that is, how does one, address those issues in a rural area versus urban underserved? Are they the same mechanisms? I know that's the first one to start off with, right? Anybody can take this one.
Okay,
It's open.
I have something to say. Okay, I would say it more so of when you go in, you're going into a doctor's office either way. So if it's literature there stating about the food equity or programs where you can go, people will pick that up and read it. They may not do it right then and there, but they will read it. It's just getting the information out there.
Yeah. And I will jump in and say that I agree with Dorothy about access to information and to services may be different depending on location. So, and I think Macy kind of alluded to this, the need for better coverage of these services for all cancer patients. So oncology, dietetics, and that kind of thing. And a recent survey by the Academy of Nutrition and Dietetics indicates that the ratio of oncology dietitians to cancer patients in cancer centers is like 1 to 2,000 patients, and it should be 1 to about 120 to provide evidence-based services. And we've also been talking a lot about COVID and how that's changed things. And I do wonder whether sustaining telehealth visits is an opportunity to try to kind of address some of that lack of access for people in rural areas. So, we also talked about, how these programs are paid for, and most of them are kind of grant funded or philanthropy funded. And if you're not in a big cancer center or a big hospital, they just may not exist at all. So I think there might be some opportunity and lessons learned from COVID in how to expand access to some of these programs to those places that just don't have it or don't have enough of it.
Thank you. Jessica, you were going to jump in, or?
Yes, I was going to add a couple of things just from the perspective of working for a medically tailored meals entity. And so, we serve the state of Massachusetts, but when you're asking the question about food access or throughout the different area in urban versus rural areas throughout the state, and what programs are available, our ability to provide meals throughout the state has only really become more possible as federal funding has started to be available for our agency, which has only really come within the past 2 years, and there's a time limit on that. And so it really comes down to, we can service the immediate area around Boston much more easily than we can reach out to Western Massachusetts, simply based on what funding we have available. And so, that's a policy piece that clearly, we've been working here to address as much as we can, but can see it firsthand how many people we're able to serve in how many different communities based on, you know, what federal funding we have available to us.
Thank you. And Gwen, next question.
Yes. So I think one of the themes that we've been trying to bring up in this panel and throughout the day is, how do we go from knowing there is a problem to actually creating solutions to a problem? And Stacy, I know that there's a lot of things that you're doing that really are directly about creating solutions to problems. And you mentioned the food pantry briefly, along with could you just talk a little bit more about that and the idea of giving and receiving there, which was, I thought, a very compelling idea.
Sure, I'm happy to. Thank you for that question. Our work started more than 10 years ago with an observation by a hospital chaplain in our children's hospital that families were going hungry while caring for their children. This was a call to action, and by partnering with the Greater Chicago Food Depository, we were able to implement an emergency food solution very, very quickly. I never imagined 10 years later we'd be operating 11 food pantries in our medical center and replicating the effort elsewhere. But as typically happens when a problem percolates from the ground up and a solution is implemented using existing structures and by partnering people who know the problem best with people who have some power or control in the institutional setting, you can get to sustainable solutions. The feed first approach, we did study other hospital-based food systems, and we really put a line in the sand that there would be no questions asked. There would be no prescriptions. There would be no asking for evidence that somebody's going hungry, that it would be an absolutely no barriers, stigma-free solution. And we've been able to stick to that. One concern I've heard from other settings is like, well, how do you know people really need the food? How do you keep people from stealing the food? And my answer there is, if it's free, it can't be stolen. And the repeated evidence of people who receive from this model, finding dignity and the opportunity to give back to the system far outweighs any evidence of people who are not in need of the food using it. Lastly, I'll say that our system allows for anybody in the four walls of the medical center to make use of the food. And of course, we know in hospitals that sometimes staff, trainees, in addition to family members caring for patients, can be food insecure. This is a difficult problem to talk about because it speaks to the structures that determine how we pay people who work in our health systems. But we know that staff are making use of our food pantries, and gathering data on this youth gives us evidence that we need to advocate to change the underlying structures.
And I think also it just reinforces what you had said earlier about it's a state, not a trait. And when I was thinking back to Raphael's talk about the recording I think he was from San Antonio. I mean, that horrendous, this horrendous idea of what people who are hungry deserved. And there continues to be this notion of who's deserving and who's not deserving, no matter where you're going in this. And I think it's really important to think of it as a state. And it's also really important to do what Shanta Chambers talked about, which is looking at it through an equity lens.
Yeah, if I could add one last point on that, trust and the earned distrust in the medical system, meaning we've treated people in such a way over time that people legitimately don't trust us. One of the most important indicators of hospital food insecurity was whether the parent or caregiver trusted that the child would be okay if left alone in their hospital room. So parents who did not trust that their child would be okay were going hungry because even if they could afford to get food off the unit, they simply weren't going to leave their child. So this underlying structure, somebody asked a question about it, the underlying structures have to be addressed before we will be able to sustainably alleviate the problem of hunger in the hospital, let alone in society at large.
Great. Thank you.
When can I take the question on how
Please.
come we've had food insecurity even before COVID when so much food goes to waste?
Absolutely.
And it's the same question as to how much do we have so much poverty in Connecticut, which is the wealthiest state when you look at income per capita. So in short, the answer to that very thoughtful question from my point of view is that it is a very clear manifestation in the enormous inequities in the distribution of power, in the distribution of wealth, and in the access to basic human needs, including food. And that is where I think that as a country, we're pretty soon going to have to make a decision on whether we're going to respect human rights or not, because it is no longer possible, I think, to continue through this path. I think that at the end of the day, public health and human rights are 100% compatible with each other, and they're both telling us, they're both sending us very strong signals, and human rights have done that even for longer than public health, that unless we address these enormous inequities, it is going to be very, very difficult to really make much progress in these incredibly unjust and unfair social, political, and economic systems that surround us.
So picking up on that, question I have is, how do we reimagine the sort of system? Now, when we talk about most of the food insecurities, we have big academic institutions that are doing these wonderful things. We know that most of the care that people get, particularly cancer patients, 85% of that is outside of our sort of NCI designated centers or our academic centers. So how do you envision, as we move forward, better utilizing, for example, community health centers? Now, for transparency's sake, I'm a big fan of federally qualified health centers. I used to run a network of someone in Chicago called Miles Square. But the envisioning of 1960, when those things came on, it was supposed to be the undergirding of how we got out to these places. How do you think your programs could be scaled or could interface with using those networks of community health centers? And are we thinking about, are we maxing out the potential of the FQHCs? I'll just leave that open to anybody. I know, right? I come with those crazy questions. I know.
So Bob,
but I don't want to dominate on the conversation, so I'll let somebody else.
Well, I just spoke, so I don't want to speak either if someone
Macy,
else wants
Jessica,
to go.
Kristen, Dorothy.
Well, I think there's an opportunity, and going back to Hillary's talk about screening and intervening, and one of the policies that she really honed in on was a small p policy of universal screening for food insecurity with the hunger vital signs. And I think there's certainly examples of federally qualified health centers and community health centers doing that. But I think that that's something that is ripe for scaling to really start to identify, through the medical neighborhood that treats, the most vulnerable in our society, to kind of scale that universal screening and then implementing the other policies she talked about to be able to intervene in a way that's effective.
Rob, this is Ann. I'd like to add to that conversation just a bit. I would say that one of the things that we've done, I've had the pleasure to both work in Dr. Lindau's lab, work in Stacy's lab, and to also watch the Feed First model in real time. And the Feed First model also has a advisory panel, advisory group, and it gives opportunity for interested community members, community stakeholders to participate in conversations and to learn about the programming behind how an organization like Feed First operates. And what I think I've seen happen now, and I'm probably a really good example of this. My initial work was very hospital facing, very institutionally facing, and I supported the pantry that is within the cancer center. because Stacy so graciously helped me to bring that to life in November of 2017. And so I have a certain sense of responsibility for that pantry. But over time, because of discussions and interactions and even mentoring, I would say that it has given me the wherewithal to turn and to now create an organization that is community facing. And so we've talked to, Stacey and I have talked in the past about how do you create models where community organizations that are interested and who can reach people that are in these spaces and places that the institutions cannot move into as nimbly as individuals can. And how do we take that expertise beyond these ivory walls of these institutions, to Hillary's point, and break down barriers to what can be funded, what can't, and really help small or growing or emerging or passionate community-based organizations become some of the ambassadors of this work and even carry out the work. I mean, I'm really very happy for what we've done, but I know that it is grounded in what I got in being a part of the Feed First family and really learning how this works. So I offer that as a model, as an idea of how we can do some of that work.
And if I can just add briefly, Anne, you set my soul on fire, because I think it's also asking ourselves, have we maximized the capacity of our community-based organizations and the role that they can play? And it's the realization of, when you talk about reimagining, I guess we have to also ask ourselves, are we ready to be provocative enough that we stop operating in these silos and really begin to be intentional about either local and national partnership, regional partnerships, whatever it is, because it's to strengthen our collective capacity that is going to be warranted if we're really going to bring forth tangible solutions. So when you talked about reimagining, let's reimagine new policy structures in place that will continue to perpetuate food insecurity, but really undergird people and meet them at their points of need.
Thank you.
I think that's one of the beauties of a giving and receiving model. We think about emergency food support as giving food, as charity, as unidirectional. But when you whatever system you create to wherever along the pipeline to address food insecurity for people living with cancer and their caregivers, imagine what it looks like if it's set up in a way to invite people not only to receive, but to give. And it's the inviting people to give. Anne is one of several examples of people who encountered the food pantry in the hospital and even realized for the first time food insecurity is a thing, that other people are suffering. And I could give 9 or 10 examples of people who encountered this giving receiving model and then thought to themselves, well, what can I do to help? Where along the pipeline can I help solve this problem? And Anne is a perfect example of that. I just think that's a lesson I've learned from doing this work that applies very broadly, not just to the problem of solving food insecurity, but how, when we're helping to alleviate suffering, are we giving human beings an opportunity to create meaning and to give back to others? That's a very important part of living with cancer.
Thank you for that.
Rob, is there time for a quick comment on your structural question?
Absolutely.
Yeah. So I have not worked in the area of cancer, but I have worked fairly successfully in the area of integrating community health workers in the area of type 2 diabetes as part of the healthcare management team. The work that we have done, the randomized control trials have been done elsewhere. It is very clear that when the CHWs are well-trained, well-supervised, working side by side under the supervision of registered dietitians and medical doctors and certified diabetes educators and so on, they make an enormous difference. We just heard from our dietitian colleague the enormous lack that there is, the deficit of dietitians available. Very few of them are actually come from minority groups. So I think like the patient navigators, the CHWs have a very big role to play. But you know what? We have been getting grants for 30 years to do this work. And it's still not sustainable, and it will never be sustainable until it gets reimbursed by Medicare or Medicaid or other insurance systems. So I think that, you know, we have made a lot of progress over the past decades on community-based participatory research. We have wonderful, wonderful people and examples such as the ones that have been shared here already. We have the national network of CDC prevention research centers. We have done a lot of our part. You know, where is the government? You know, where is the opportunity to truly reform the social services and healthcare systems so that the people working in the community and their agencies can be equitably reimbursed for the amazing work that they do. So to me, that is a huge structural barrier that is still not allowing for a lot of these elegant and innovative community-based participatory research to truly be translated into sustainable programs.
Thank you. Gwen?
Yeah, so I think that's actually, these are kind of perfect segues into maybe, I guess we're getting, as I'm looking at the hour, final question to the panelist, which is that, you know, we've talked a lot about, I think Raphael, you know, just pointed out that we've been getting grants for 30 years for this. PAF has been in existence for 25 years. I've been doing patient advocacy for 25 years, and things haven't changed. We're still dealing with these band-aids of social needs. So how do we, and I think the pandemic showed us a very, very specific socio-political moment. But now we're in a new socio-political moment, and we have a proposal, a president and vice president who've made a proposal of a very large infrastructure approach, which includes a much more holistic approach. And I think we're seeing a more holistic approach to really addressing inequity and addressing structural racism and structural barriers to health and well-being and rights. So my last question, which is just a kind of how can we go to action, is what do you think this socio-political moment affords us as opportunities to actually make change, not just describe the problem? And
we'll take any of the panelists.
We'll take any of the panelists.
Macy, Jessica, Kristen, Dorothy.
I would say, just do it. I mean, it's like Michael Jordan, just do it. We're saying that we're studying this, we're doing this, we're doing that. We just need to get together and do it. And what I mean by with the different panelists and everything, as a group and whole, put it together and put it out there. That's my opinion. Because I know quite a few people that's going through cancer now could really use this. Mm-hmm. So we need to put it out there.
Right.
Just do it.
And Dorothy, the just do it also builds on what we were talking about a coordinated approach of people, all, you know, as you said, all of the people who come from very different backgrounds, who are participating in, who are panelists, who are speakers, who are participating in the in this webinar are just it's 200 some people. It's just a small group of people that are concerned about this and devoted to this, and we can just start with this. If we could just start by doing it among the people who are here, maybe we could make a difference.
I am doing it with Ann Jackson, so I'm in.
See, you're in.
I'm
okay.
in.
Great. There you go. There you go. So I think we just have one more quick question that I want to squeeze in. It's from the audience, and I think, you know, Dorothy, you bring up a really good point about getting it done. But there's a question about how do you address the agencies that are put in place to assist with this issue of food shortage And when people ask for assistance, they're judged by their income and might be turned down. And I say that in the context that many of us know that we, through this COVID, the impact of increased numbers of undiagnosed cancers is likely to get worse. So this issue of food insecurity isn't some sort of theoretical model. It's happening and it will come into play significantly. So as you're thinking about that, how do we address those agencies that are put in place that assist with the food shortage when people are asked for assistance? They're judged and might be turned down. So any of the panelists, we'll open it up and that'll be our last question for this session.
Well, I will answer both this and the other question at once, which is to say that there was a lot of press around food insecurity rates rising and maybe even doubling with COVID-19. And I think that was very, very true within some populations that are historically vulnerable anyway. However, I think food insecurity rates, we are learning, did not go up as much as we thought. And that's because we put into place very, very effective solutions. Unemployment works. Child tax subsidies work. Increased access to school meals and SNAP and summertime meals for kids work. And so I think that one of the key lessons we have to take away from this historical moment is that we know how to solve this problem. It just takes political will and it takes investment. And it takes us really stepping up and saying this isn't acceptable in the United States. And I think that the question around how do you assist with agencies that have to turn people away because of income, if a household is in need, we should, as a society, decide that it isn't acceptable in the United States to be going hungry. And that should not be a reason for an individual household to be turned away.
I love that. And that will have to be the last comment for this session. I am going to turn things over to Ann Jackson, who I'm going to say this would not have happened without Ann's sort of advocacy for bringing this issue to the forefront. So Ann, I want to thank you so much. And I want to have you just deliver some of our concluding remarks, and then I'll wrap up.
Thank you so much, Rob. I am just so honored to be here with this conversation, in this conversation, because I do appreciate the National Cancer Policy Forum accepting my nudge almost 3 years ago to start this conversation and being receptive to having it. And it is a dream come true to see this conversation that we're having today. So I'm grateful to be here. And I'm also very thankful for all of you who have stayed with us on this conversation and will continue to journey with us, as Gwen said, because it will take the persistence of all of us to move this forward. But I'm Ann Jackson. I'm a mom, I'm a wife, I'm somebody's neighbor, and I'm a person who's lived beyond a cancer diagnosis. And I am a believer that food is medicine. And as we've been talking about all day, I believe that the right to food, the right to nutrition is a human right. Over the last 110 minutes, we've learned that healthy, nutritiously dense foods are essential components of wellness, especially when someone is facing a life-altering diagnosis such as cancer. And we know that many cancer patients not only face a cancer diagnosis, but they may also be living with other comorbidities that may also impact their nutritional needs. We've also heard from experts that the lack thereof can have a significant impact on the overall health and well-being, not only of the person with the cancer diagnosis, but also with their families. Our research scholars drew our attention to the complexity of the dilemma and the gaps in the work currently being done. We also became well-versed in the idea that creating sustainable paths to ensure that all cancer care providing centers are able to provide a variety of culturally affirming nutritional services is a matter of health equity and of social justice. And we've also talked about the idea that this lack of equity is grounded historically in some of the political decisions that have happened decades prior, but that does not mean that they are so entrenched that we cannot make a difference today. Despite these hurdles, we've discovered and learned and talked about that healthcare centers and community-based programs have created programs based in open access, medically tailored, and serving those in need before asking questions. These models are working and should be adapted and scaled to more places. These models are moving the idea of healthcare systems toward addressing issues in innovative and user-friendly ways, and recognizing that the issue of food insecurity is not always a chronic state, and that sometimes we have to be flexible to be able to provide individuals and families the nutritional needs, the nutritional support that they need in a moment. And their moment may be fleeting, but for others, it may be a long-term need. Their intentional programs are helping to reduce hospital visits, reducing overall medical costs, and to those experiencing a cancer diagnosis, the burden of cancer itself. What we have to think about now is what's our next? How do we move forward? And to Gwen's point, and to Raphael's point, where is sustainability? And sustainability is at the table of the national conversation about making this not something that people are doing in isolation around the country, but that it is a norm, that cancer centers, places where people receive cancer care, are asking questions about nutrition, providing services to everyone. So I want to encourage us to take our curiosity and interest in this topic and transcend to becoming unapologetically passionate and to run with perseverance in all of the settings where we have influence and agency, at the local settings, at our state levels, nationally, and wherever possibly globally. I want us to ask questions of our facilities, of our funders, and of our clients and patients so that we have a better understanding of what the need is. Earlier today, we learned that perhaps as many as 56% of cancer patients who fall into particular demographic groups may be experiencing food insecurity. That's too high. 12%, that's too high. We need to do something. We also need to be change agents. Think about ideas at the local level. If your institution already provides food on a snack cart, how can you make that more nutritionally meaningful? How can you think about offering, or can you think about offering vouchers to families who are at your care center for longer than 3 to 4 hours, a voucher for either a meal or parking? Saving those few dollars might seem insignificant to you, but may be monumental to them. And lastly, I would encourage us to stand together, as Gwen said, to talk locally, to talk at the state level, to talk nationally, and to really try and be invited and maybe even knock on the door of where real policy is being discussed. Creating advocacy groups, supporting community-based organizations so that they can go out and do the work and we do not have siloed experiences. I hope by now we all subscribe and believe that food is medicine. In doing so, we must collectively believe and go out and do the work that where there is a need, we must stand together and feed. Thank you very much for your time.
And I want to thank you for those parting words. I also want to make sure that I thank everyone that was involved, our sponsors, the NTPF, the other groups that were involved in helping us to organize. Clearly, I want to give the folks at the NTPF staff and others a hand for helping us put this together. And I also want to just say to the speakers and panelists, thank you for making this real, and thank you for making this happen. And Anne, thank you for your passion around bringing this to the attention. I hope that this is the first of, not the first and only conversation. And to your point, we need to get beyond identifying that's a problem, and sort of as a group, as a country, and as health providers all over the United States, getting together in a more organized fashion to sort of not only eradicate cancer, but really hopefully eradicate hunger as well. So with that, I will say thank you for having, for making this a wonderful sort of couple hours. And we look forward to more deeper discussions, and clearly, as Dorothy sort of said, just getting it done and getting, action now. Talk is good, but action is better. So we'll be looking forward to what policies will lead to increased action. So I want to thank you all. Have a wonderful rest of your day.